Dear students, in this video I will talk about the gastrointestinal tract, second part of the gastrointestinal tract, including the stomach, the small and the large intestines. So let's see how these organs are located inside our abdominal cavity. So after the diaphragm, which would be located here above the liver, we have the transition between the esophagus and the stomach. And the stomach continues in the duodenum, jejunum, and the ileum. These are the parts of the small intestine. And then on the right iliac region, the small intestine go and continue in the large intestine, starting with the cecum, which has the appendix. Vermiform is hanging from it. Then we have the ascending colon, the transverse colon, the descending colon, then the S-form sigmoid colon, and the rectum at the end. So we will go one by one and see the topography and the functions of these organs. So let's start with the stomach. So the stomach is located just below the diaphragm, actually just below the left dome of the diaphragm, and it is located in two regions of the abdominal cavity. The middle upper region is called the epigastrium, and we have the left upper region, which is the left hypochondrium below the left costal cartilages. Okay, about the 9 regions of the abdominal cavity, you will hear in the lecture about the peritoneum and the abdominal cavity. So I won't go deeper into this topic. Okay, but I wanted to mention that the stomach is located in these two parts, in these two regions, so epigastrium and left hypochondrium. And approximately the stomach is located between the 11th thoracic and the first lumbar vertebrae. So in the level of these vertebrae, in a lying position at least. In a standing position, the stomach can sink down until L3 or L4 even. The parts of the stomach. So the first part where the esophagus-stomach transition is found is called the cardia. And then we have this upper left part of the stomach is the fundus, which contains an air bubble, and this is what we find directly below the left dome of the diaphragm. Then we have the body or corpus, and the last part is the so-called pyloric part, which ends in the pylorus. The pylorus is actually a sphincter muscle at the end of the stomach, by the transition between the stomach and the duodenum, and this is constantly constricted and only allows the content of the stomach to pass through and pass to the duodenum. We can see some peritoneal structures as well in the picture. As you know, the stomach is an intraperitoneal organ, which means that the peritoneum surrounds the stomach all over. And we have two major peritoneal structures. One is visible here between the liver and the stomach. This is the lesser omentum, or more precisely, the hepatogastric ligament. This is actually the left side of the lesser omentum. This is a double-layered peritoneum connecting the liver with the stomach. And the lesser omentum attaches to the so-called lesser curvature of the stomach, which is found here on the right side of the stomach. And the convex part of the stomach is called the greater curvature. And from the greater curvature, we have also a peritoneal structure hanging down and covering the organs of the abdominal cavity, and this is the greater omentum. function of the stomach is to produce the gastric fluid. The gastric fluid will be produced by the glands of the stomach and actually also the surface epithelial cells of the stomach. What we can see in the picture is actually the mucous membrane of the stomach. The mucous membrane consists of an epithelium, as always. In this case, this is a secreting, simple columnar epithelium, which secretes mucus. This mucus will cover actually the surface of the stomach, which prevents the autodigestion of the epithelium, so protects actually the tissues of the stomach against the acids inside the stomach and against the enzymes, the digestive enzymes in the stomach. The surface of the stomach has pits, so little invaginations. Actually, these are the gastric pits, and deep down, the gastric pits will continue in the gastric glands. These are simple or ramified tubular glands. And the glands are composed of different kinds of cells. At the upper part of the glands, we find the mucous neck cells producing mucus. Then a little bit lower down, we can find the parietal cells. The parietal cells will produce the hydrochloric acid of the stomach, which will give the acidic pH of the stomach, which is around 3, pH 3. And the hydrochloric acid will be actually pumped out by these cells through ion pumps, through active ion pumps in form of hydrogen and chloride ions. And the parietal cells also produce the intrinsic factor, which is important for the resorption of the B12 vitamin. And at the lower part of the glands, we can find the chief cells, and these will be the cells which will produce the enzyme, the digestive enzyme of the stomach, which is the pepsinogen. The pepsinogen is the inactive form, so it will be secreted in an inactive form, and inside the lumen it will be activated and it will become pepsin, and this will be able to digest the proteins. And then we have some other cells, enteroendocrine cells, which can secrete different hormones into the bloodstream. One of the most important hormones is the gastrin, which activates the secretion of the other glands. A very common and frequent disease of the stomach, and actually after the stomach, the duodenum could be affected by this disease as well, and this is the ulcer. The ulcer could be the causes of the ulcer could be stress. There could be a drug-induced ulcer as well, mostly because of taking NSAIDs or aspirin or SSRIs. And the third and quite common type is caused by a bacterium, the Helicobacter pylori bacterium, which is a very aggressive bacterium and very hard to get rid of this bacterium. So the prevention would be actually very, very important. After the stomach, we will have the small intestines, and the first part of the small intestine is the duodenum. The duodenum will be better visible if we remove the stomach and the greater omentum. And this is what you can see in this picture. Actually, we also removed the liver here. So behind the stomach, we can see the spleen and the pancreas, and the duodenum will be also visible. The duodenum is a C-shaped organ. The upper part, as the continuation of the stomach, is covered by peritoneum, so it's intraperitoneal. but the rest, the descending part and then the lower part, the inferior part, will be already retroperitoneal. So only the anterior surface will be covered by the peritoneum. Okay, so it has this C shape, and in the concave part, we have the pancreas. Okay, the pancreas will be a very important gland producing the digestive enzymes, which will be secreted into the duodenum. In this picture, you can see how the main pancreatic duct, the duct of the pancreas, will open into the descending part of the duodenum. This is the greater duodenal papilla where it opens. And actually, usually it opens together with another duct called the common bile duct, which brings the bile from the gallbladder. Okay, so from the pancreas, digestive enzymes arrive into the duodenum like amylase, aranase, trypsin, chymotrypsin. All these enzymes will be produced in an inactive form, and then they will be activated inside the duodenum, and actually this protects the pancreas from autodigestion. So the bile and these digestive enzymes usually arrive and open together into the duodenum through the greater duodenal papilla. The duodenum will continue in the jejunum and ileum. You can see that these are very, very coiled intestinal loops, which will take most of the space in the abdominal cavity. And with this, actually, the duodenum is mostly found in the right lateral and in the umbilical region, and the other parts of the small intestines will be found actually in all, or could be found in all 9 abdominal regions. Okay, so everywhere where they have space, they will fill out the space. It's a quite long tube actually, and it is coiled up so it can pass into a smaller space. The function of the whole small intestine is to digest and to resorb the nutrients, and this will be done by the mucous membrane of the intestinal wall, and it's very important to know that the whole wall structure is made up in a way that it will increase the surface, the whole surface of the small intestine will be increased in a very, very so actually it's almost like a 200-fold increasement. This increase in the surface is done by 3 different structures. There are the folds of the small intestine called the Kerkring's fold of Kerkring. This is produced actually by the submucosal layer, the Tunica submucosa. So these are the folds, which you can see here. The folds are circular folds. These could be visible, or these are visible actually macroscopically also. And on the folds, we can see some protrusions, and these will be the villi, the intestinal villi. Okay, this is the second structure with which we can increase the surface. So the first is the folds. A folded surface is always bigger than an unfolded, a straight one. Actually, then this the villi will function in a similar way. And on top of the villi, we have the surface epithelium, which is a simple columnar epithelium with brush border, so with microvilli. And these microvilli will further increase the surface. Okay, so we have the mucous membrane, tunica mucosa, with the three main layers that we always have in the GI tract is the epithelium mucosae, the lamina propria, and the lamina muscularis. Then we have the tunica submucosa with connective tissue and the submucosous plexus. Then we have a muscle layer, tunica muscularis, with an inner circular and outer longitudinal layer, and in between the two layers we have the nerve cells and nerve fibers of the myenteric plexus. And as the outermost layer, we will have either tunica serosa or an adventitia. It depends on the peritoneum, actually. If an organ, if the small intestine is intraperitoneal, so it's covered fully by the peritoneum, then it will have tunica serosa, a mesothelial layer outside. If it's retroperitoneal, then it will be covered by a tunica adventitia, which is a loose connective tissue. And the duodenum, we mentioned that, or maybe we haven't, but the duodenum, only the first part of the duodenum is covered by peritoneum, so the first by the continuation of the stomach, intraperitoneal, and then the rest, the main part of the duodenum, will be already retroperitoneal, so only the anterior surface will be covered by peritoneum, and then the jejunum and the ileum will be again intraperitoneal, so they will have a tunica serosa as an outermost layer. The difference between duodenum, jejunum, and ileum is actually in their submucosal layer. In case of the duodenum, in the submucosal layer, we have glands which will produce bicarbonates to neutralize the acidic fluid coming from the stomach. In the jejunum, this picture is from the jejunum actually, we do not have any special structures in the submucosal layer. And in the ileum, we have lots of lymphatic tissue in the submucosal layer. And this lymphatic tissue is usually arranged in lymphatic follicles, and the lymphatic follicles of the ileum are called the Peyer's patches. Let's see again the structure which can increase the surface of the small intestine with a higher magnification. So first we can see the folds, which are circular folds. These are called the Kerkring folds. On the surface of the folds we have the villi, villus in singular, and then on the surface of the villi we have these simple columnar epithelial cells which have microvilli on their surface. So these are the three structures which will increase the surface. And one more important thing is that in the axis of the villi we have actually a lymphatic vessel which is called the central lacteal, and it's interesting that the central lacteal not only drains and not only collects lymphatic fluid, but the absorbed or resorbed lipids will be resorbed actually into the central lacteal and will be transported by the lymphatic vessels. Okay, the other nutrients will get into the venous blood, but the central lacteal will collect the lipid, the resorbed lipids. After the ileum, in the right iliac fossa, or right iliac region, the small intestine continues in the large intestines. It will start with the cecum. The cecum has a small appendage called the vermiform appendix, which is approximately 8 centimeters long, and it's hanging from the cecum. And then the cecum will go upward in the ascending colon. It then turns to the left, that will be our transverse colon, and then turning downwards we have the descending colon, then the S-shaped sigmoid, and the last part will be the rectum. As for the function of the large intestine or colon, it's very important that the water and ions will be resorbed here in this part of the digestive system. So the appendix is an important lymphatic organ. It is actually like the tonsils around the oral cavity. And we need this because we have different bacteria in the large intestine and the small intestine, and these lymphatic organ will prevent infections here in this area. Okay, and as you may know, the appendix gets inflamed quite easily. This is the appendicitis, which is a quite common and quite dangerous infection, or could be dangerous, because it can cause perforations on the wall of the intestines, and this could be life-threatening as well. The large intestines are, as we saw it in this picture, are surrounding the small intestines. Okay, like this. Okay, so the different parts of the colon lie in different abdominal regions. Actually, except for the umbilical region, so the middle region, in all abdominal regions we have some kind of colon parts. Okay, so in the right iliac region we have the cecum, right lateral region, the ascending colon, right hypochondrium, we have the so-called right colic flexure, and so on and so on. Okay, and we can see in the picture as well that there is a difference between large and small intestine, and it's not just the thickness. And this is very important during operations where the surgeons don't see that much, but they can palpate different things on the surface of the organs, and they can differentiate between large and small intestine in a way that the large intestine has some structures on the surface which are palpable. Okay, for example, these lines, this stripe which runs here, this is called the taenia, and actually this is the thickened longitudinal muscle layer in the tunica muscularis, and this is a little bit more solid than the rest of the tissues, and this can be palpated. The other structure which is visible in case of the large intestine are the so-called haustra coli, the colic haustrae, which are these outbulgings actually between two folds, two so-called semilunar folds of the large intestines, which are visible here. So the large intestine, the colon, is also folded, not as much as the small intestine, but still, and between two folds we can see a bit more wider area, which is called the haustra. And the third characteristic of the large intestine is visible in this picture, and this would be an appendix, which is actually a fatty appendix called the epiploic or omental appendix. The function we do not know yet, but it's very, very important when we would like to differentiate between a small intestine and large intestine loop. So at the end of the colon, we will reach the rectum, which already lies below the peritoneum, and actually most of it lies already infraperitoneal and is located in the pelvis. And there are two important things to mention here. One is the sphincter muscles. We have two different sphincter muscles. We have an inner one, an internal one, which is actually composed of the circular muscle layer of the tunica muscularis. And we have an outer and external anal sphincter, which is composed of skeletal muscle, and so it's innervated by our somatic nervous system, so it's a voluntarily regulated muscle. Okay, while the internal one is smooth muscle, so it's innervated by the autonomous nervous system, so we cannot regulate it in voluntarily like the external one. The other important thing with the rectum is the venous drainage of the rectum. And this is important because of the venous drainage of the rectum, we can use suppositories in the rectum, which are drugs used mostly by small children. And these could be used because the upper 1/3 of the rectum is drained by veins which will drain into the portal vein. The portal vein reaches the liver, where the content of the vein will be at least partly metabolized and detoxified. So actually the effectiveness of the drugs will be lower, and the lower part of the rectum, which is important for taking suppositories, the lower 2/3 of the rectum, and the venous blood from here will be drained towards the inferior vena cava. And the inferior vena cava doesn't enter the liver. It goes behind the liver and enters the heart directly. And because this vein doesn't go to the liver, we can use the suppositories much more effectively, because we can calculate the dose much precisely, which is very important in small children, because we can overdose small children much simpler than an adult. And if we use the drugs as a suppository, then we can calculate the dose much better, because it won't be metabolized in the liver. And the effect is also quicker because it gets into the systemic circulation faster than as if we would swallow the drug. Okay, so this is why it's important to know the venous drainage of the rectum. So the lower 2/3 of the rectum will be drained by branches of the inferior vena cava, okay, the internal iliac vein, and so on. And the upper 1/3 will be already drained by the portal vein, tributaries of the portal vein, just like the other parts of the intestinal system. Okay, so if we swallow a drug, so take it orally. I already mentioned this in the previous lecture as well, but it's very important. If you take a drug orally, it will be resorbed through the digestive system, through the small intestines mostly, and it will get into the system of the portal vein, which means it will be metabolized in the liver first. So the drugs use their effectiveness a little bit, because the drugs are considered as toxic agents as well, so it will be also detoxified. And so drugs taken orally are less effective, so actually we have to take a bigger dose to have the same effect than a drug which we take as a suppository, or even a drug that we take sublingually, which I mentioned in the previous lecture as well. Okay, so this is a very important thing to mention here. And as last, I would like to show you this picture about the histology of the large intestine. It's quite similar to the small intestine. The biggest difference is that there are no villi in case of the large intestine. So there are these protrusions still. These are the folds produced and elevated by the submucosal layer. But on top of the folds, we do not have any villi. We only have the surface epithelium and some glands. And the epithelium is actually the same as in the small intestine, so a simple columnar epithelium with brush border. So it still has microvilli for the resorption. So from the free structures which increase the surface in the small intestine, in the large we only have the folds and the microvilli and no villi. But otherwise the wall structure is the same. So we have a mucous membrane, the tunica mucosa, with epithelium, with lamina propria, and with a thin layer of lamina muscularis mucosae. Then we have the submucosal layer with the connective tissue. Then the tunica muscularis with the inner circular and outer longitudinal layer. And as the outermost layer, we have the tunica serosa or adventitia, which again depends on if the organ is intraperitoneal or not. The intraperitoneal part of the colon is actually the cecum, the appendix mostly, the transverse colon, the sigmoid colon, and the first part of the rectum. The ascending colon, the descending colon, and the lower parts of the rectum are extraperitoneal, so they lie either behind the peritoneum, like the ascending and descending colon, or below the peritoneum, like the rectum. Okay, and this is what I wanted to tell you about the GI tract, and thank you for your attention. Have a nice day. Bye-bye.